We're taking a brief interval from our Confidence Interval podcast series to share the important research that's happening around obesity and diabetes. I'm Pam Mungrew, and I'm on a quest to find out more about the research happening at the MRC Epidemiology Unit and the IMS Metabolic Research Laboratory at the University of Cambridge. Gestational diabetes occurs during pregnancy for a multitude of reasons. Being overweight or obese can be a factor, but some may be genetically predisposed to developing the condition. Researchers from the IMS Metabolic Research Laboratory are investigating the interventions pregnant women can use to mitigate the onset of gestational diabetes. I'll let my guests introduce themselves.
Okay, so my name is Adriana Córdova Casanova, and I'm a research associate here at IMS.
My name is Denise Fernandez-Twinn. I am assistant research professor in Professor Ozanne's laboratory, also at the Institute of Metabolic Science.
I am Dr. Laís Vales, Mennitti, and I am also a research associate in the Ozanne lab.
Gestational diabetes stems from the fact that during pregnancy, which is the period of gestation, the body normally is primed to become insulin resistant, and it's the hormones that are specifically expressed in pregnancy that cause the body to become insulin resistant, so that the main effect being that glucose or nutrients can pass over to the growing fetus more efficiently. And so what happens is incident rise in the levels of glucose in the body that helps sustain the growing fetus. That's in a nutshell what it is. During gestation, that happens normally, but in a case when the mother is already primed to become on the way to becoming diabetic or pre-diabetic, that causes an additional stressor on the mother, and the hormone insulin is becoming even more repressed in the mother.
Is this something that can be an issue for women maybe genetically predisposed because of family history? Is it so? Could they get gestational diabetes? May that have an effect on them?
So there is some risk factor to get gestational diabetes. For example, genetic factors like family history, but also, for example, if a woman is suffering obesity, there are higher chances to get gestational diabetes.
If there are metabolic changes in the woman, there are higher predisposition to develop gestational diabetes.
That can be due to dietary intake, as well as other environmental risk factors that can add to the risk of developing gestational diabetes.
So what is the effect then on pregnant women who develop this?
So their glucose levels go a bit rampant, and normally you have insulin, which can dispose of that glucose by shuttling it to storage areas like the liver, the muscle, and storage, especially in the adipose tissue, which is fat. And that's what would not happen in a normal situation. But when the woman becomes pregnant, all that glucose is actually a good thing because it's redirected to the fetus, which is growing. But on the downside, if you don't control it, in a case when there's even more insulin than would be in a normal pregnancy, that insulin tends to work in a way such that the glucose passing over to the growing fetus is in excess, and then you can get bigger babies, macrosomic, what we call macrosomic babies, which are bigger than normal for the gestation period that they're of age of gestation, excuse me. And that lends itself to even more difficulties because the mother will have problems giving birth to a bigger baby.
I mean, I have a lot of other questions about this, but I think one of the most important things I should ask now is what is the research that you're doing, and how do you hope this will positively impact women who are having to deal with gestational diabetes?
So the main concern is the gestational diabetes for the mother, because that can predispose her to future type 2 diabetes. So in women who have gestational diabetes during pregnancy, 5 or 10 years down the line, they can develop type 2 diabetes, or they can also develop cardiovascular disease. They're all tied to this cardiometabolic syndrome, and that can begin with the gestational diabetes, because that already shows up symptoms of a woman being unable to manage her glucose, and that sets you up for more disease disposition in later life. We're studying the development of disease in the offspring in later life, and how we're going to do that, or how we have done that in the past already, is to try and intervene with exercise, nutrition. Metformin is another intervention that we're using. And we're also looking at the Ozempic, or what is broadly termed GLP-1 receptor agonists. So Ozempic is another focus. Mounjaro is another weight loss drug. But both of these drugs are also anti-diabetic. And in fact, they came on the market because they're anti-diabetic. So those are the interventions that we're looking at. And how we study is in a mouse model. Do you care to explain the mouse model?
We have a well-established mouse model when we have maternal obesity and gestational diabetes during pregnancy. So we do the interventions, nutritional interventions, or metformin interventions, or the GLP-1 receptor agonists interventions. And then after pregnancy, we see the effects of this, or the nutrition, or the obesity, or diet, or the interventions. We see these effects on the health of the offspring throughout life.
Can you explain what the mice model is?
Do you want to explain it?
I can try. So the studies in maternal programming, like to study the effect of maternal obesity in the offspring, it's very difficult in humans, because in humans we can see just correlations. For example, if mothers that suffer obesity, if they have they have a higher risk for cardiovascular disease in their offspring. So it's just a correlations, numbers. But if we use an animal model under control, in a controlled environment, then we can expose the mother to a very controlled diet, and then we can study the effect of, like the specific effect of this diet in the mother, but in the offspring, in the mice. So there are no external factors or confounder factors that can affect the result of the experiment. That's why we have to use animals.
Yeah, humans, as you know, they're complex creatures. So if you try and impose a regime like exercise intervention, you don't know what the compliance rate is. And it's the same with taking a drug. If the GP says to the woman, you have to go on metformin and you have to take this dose throughout gestation, she might find, and there's some also side effects of taking drugs like that. So she might feel like she's nauseous quite a bit at the time, and she might decide she won't take it. So the compliance is variable, and you cannot isolate one factor as you can with more primary studies like mouse studies or animal studies in general. The benefit of animal studies is you can isolate one factor at a time and study causation. You can't do that in human studies.
And with animals as well, we can go deep in mechanisms. We can have specific tissues, and we can investigate exactly the mechanism of each one in the way that we want to go through. So the animal, we can focus on different tissues and mechanisms to answer our questions as well.
So once you have gone through the process of testing and researching and analyzing. What have you found so far that you feel confident enough to go and say to women of the world, these are the interventions that you should be doing in order to help protect yourself from gestational diabetes, or how to improve the condition for yourself?
So I think with exercise and nutrition, there is already a human study that is exploring the effects of that on the mother and the offspring and the babies. And that's called the Upbeat study. And that's been going on for a number of years now, 6 years or so. And they definitively showed that if the mother takes a better nutrition and a moderate amount of exercise while she's pregnant, then the babies are not so at risk of becoming obese and not so at risk of having cardiac complications in later life. It's still early days. They're only, I think, up to 6 to 12 years now. Sorry, I might have to check that. But the message is that if you can improve the negative effects on the pregnancy, and if you can alleviate the gestational diabetes, then your child is going to be fitter when they're in adulthood. But the mother also is at less risk of herself developing cardiovascular and metabolic complications.
I mean, obviously you have these interventions, this information is now getting out and about more, but how can you move your research forward?
There's always a constant battle with disease like gestational diabetes, because one individual might find that this treatment is good, but the next, it's not going to work. It's not working as well. So there's always ways you could find interventions that work for more people, a greater number of the public. It's also about getting the word out there, and then hence, your platform is really useful because it helps get the message that you want to be in the best possible health you can be while you're pregnant, because that affects not just the health of you, but it affects the health of your baby. So it's two independent lives that are affected by your health. At the same time, we don't want the mother to feel at blame, because she is developing gestational diabetes. So it's about trying to fix the problem before it becomes a problem. So yeah, in fact, we might have to go back in time to research why a person or an individual is more prone to developing gestational diabetes.
You can find out more about the work of our researchers at the MRC Epidemiology Unit and the IMS Metabolic Research Laboratory by following us on Blue Sky, Facebook, Instagram, LinkedIn, and YouTube.